name is Matthew Gibson. I'm an interventional radiologist and I work at the Royal Berks in Reading, and I've been a consultant there for 25 years. And I just got my long service award. So I started radiology after I'd done quite a long period of time in general internal medicine, hospital medicine. I had got increasingly dissatisfied as I spent more time in outpatients and doing clinics and less time seeing patients and performing procedures and dealing with the sick patients. I only ever saw them on the next morning's ward round, so I got increasingly bored with that job. So I wanted to look around for something a bit more interesting. And I had the place I was working at the time, I got friendly with some of the radiologists who said, it's such a great career, why don't you try this? So I applied for a teaching and a teaching program, and luckily got accepted. And in those days, radiology was very general. So there wasn't interventional radiology and diagnostic radiology, it was all one and the same. So I started that, but right from the start, I was pretty procedure orientated. I really enjoyed doing things with my hands. And, it was when I started, in medicine as a med student, really interventional radiology hardly existed. I know it did, but we never had any exposure to it or even saw anybody practicing it. So it was a revelation to me to see what could be done. And I remember after a year of sort of training in my first year radiology, a young man came in after a motorcycle accident with pelvic fractures and was essentially exsanguinating, and me and the senior registrar embolized this guy and saved his life. And after that, I was hooked. I knew that was like, this is what I could do. And actually, I've never looked back. I've absolutely loved it, every moment of it since then, really. So I managed to focus my training on getting more experience within interventional radiology, although in those days, there were precious few fellowships or specialist training. And I got a consultant job where we were all general radiologists, but over the next 25 years, my focus has been increasingly on interventional. So to the extent is I do virtually nothing but intervention. And when I started, that would have been maybe 20% of my job. So I've really focused on intervention because of everyone. Everyone is subspecialized and got a specialist interest. I keep saying I'm at the end of my career, but I don't feel like I am at all. So I've got to an age where I could retire, and financially that's very doable, and I could retire, and yet I have no intentions to retire because I absolutely love doing what I do. I love going to work in the morning. I've got a fantastic team of other interventional radiology colleagues, but also the whole interventional department, the radiographers, the nurses, the clerical staff. It's just such a wonderfully happy place to work and interact with nice clinicians, and I really enjoy what I do. So I can't see any good reason for me to stop. And I'm physically very fit and, just about got some of my marbles, so there's no reason for me to stop quite yet. So that's where I am currently. I've always regarded it as a great honor to be a doctor particularly, but to be an interventional radiologist, I regarded myself, it was a great honor to be allowed to treat people and really get to do all the fun bits with very few of the bad bits. And there's a lot of very special skills you need to be an interventional radiologist. So it's not just sort of manual dexterity and that heavy, but common sense and what have you. But it's kind of also to be able to make a relationship with a patient within a matter of minutes, particularly somebody who's grievously ill. You need to convince them that what you're doing is the right thing, and they need to have faith in you and have a rapport. And so actually people skills are terribly important. Also, a lot of people sort of think that radiology doesn't involve patient contact, but I would say interventional radiology has some of the most intense patient contact you can have. And we look after more and more of our own patients on the wards, which is gratifying, but I've always liked doing sort of dialysis type intervention because I see the same patients over and over again, and it's very rewarding. Sort of treating the same patients and getting to know them, and they know your family and you know their circumstance. And often I'm the consultant who knows the dialysis patients the best. And it's really nice to work to keep them as healthy and optimize what is often a bad situation, optimize their care. And it's been wonderfully rewarding from that respect. Yeah. Well, that's changed so much over the years. So people of my generation, we had always done further training, usually in medicine or surgery, and got our either MRCP, FRCS, and we were all, we were sort of middle grade doctors, registrars, and then we decided to do radiology. And of course, that was a very inefficient way of doing it, because you'd spend ages studying for those exams to completely jettison all that knowledge. I know it was useful to have that knowledge, but it wasn't essential. And so now people go into radiology at a much earlier stage, and some people might only have done their foundation jobs. And I'm sure if you look at it from an efficiency point of view and getting people into the IR workforce, you should join it as soon as you can, particularly as IR has such a good curriculum now, which gives you the grounding you need. So I think you can go in straight after foundation jobs, and there may even be a role for even sooner than that. But at the moment, you have to go onto a general radiology training scheme and then run through as an IR trainee, but they're becoming increasingly separate. I would, from my own experience, say it has been a very happy, very worthwhile, very gratifying career. It has had tough times. The on-call, getting up in the middle of the night, can sometimes be very hard. If you want there's some highs and lows. If you have a serious complication, with me, that stays with me a long time, and that can, so you get some high highs and you get some low lows, and that's a bit different to diagnostic radiology, where the extremes are a bit less than that. So you have to sort of withstand those. But I think if you can always put the patient at the center of your thinking, and if you work with people who do the same, you'll have a very happy department. And I know that that's not the case for everyone, and there's plenty of people I speak to around the country who don't have that situation. But I think you can manufacture that by your own personal attitudes and behaviors and setting an example. So I do believe you can actually. Interventional radiology is such a wonderful career, and it's not just people like me who've getting to the end of it, and it's great for us, but the new generations coming through seem to be really enthusiastic, and there's so much innovation, so much new stuff. I feel almost jealous that I'm going to miss the new things, and yet throughout my career, I'm always doing something new. Every year I'm doing some new procedure, finding out about something. You never stagnate. It's wonderfully stimulating mentally. Yeah.